I'm Dr. Cassie from Vetfolio and host of Vet2Vet, and today we're taking a deep dive into an Addisonian case study. Joining me is Dr. Audrey Cook, professor of small animal internal medicine at Texas A&M College of Veterinary Medicine and Biomedical Sciences. Hi, Dr. Cook. Thanks for being here.
Hi, Cassie. I'm thrilled to be with you today.
So as we prepared for this discussion, you made an excellent metaphor that I thought was just really fitting for these cases, that trying to find Addison's cases is a bit like searching for Cinderella. You might not find her, but unless you try on the glass slipper.
That's exactly right. That is how I think about it. And so I'm known at work for testing dogs for Addison's routinely. People sometimes roll their eyes and say, Audrey's going to think it's Addisonian. But having said that, I whisk that glass slipper out of my lab coat pocket and I try it on many of the patients that I see. And it's not common, but sometimes it fits. And so by trying the slipper on my patients, I find Addisonian patients that might otherwise have been overlooked. And so I do have this sense of what's the harm? Just see if the slipper will fit. Maybe this is Cinder's. I mean, I do end up testing a lot of ugly sisters, but sometimes I find Cinderella, and it's a very, very straightforward thing to identify when you found Addison's. And it's such a treatable disease that overlooking it is just heartbreaking. So yes, I have that glass slipper in my lab coat pocket, and I whisk it out a couple of times a week.
I love the idea of having a glass slipper in your white coat pocket. I've found a lot of interesting things in my white coat pockets, but never a glass slipper. Usually things much more unpleasant than that.
Well, that's very true. So it certainly is a change from some of the other things we find in our pockets, that's for sure. But yeah, I have a little glass slipper, and I'll just try it on and just see if it's going to fit.
I love it. I love it. Well, let's talk about a patient that you saw recently, aptly named Prince, who was diagnosed with Addison's disease. Can you tell us a little bit about Prince when he came to see you?
Yes, I'm happy to, because he's a really, really useful case. So Prince is about a 2-year-old castrated male German Shepherd. And he was adopted from a rescue group about 2 months before I first met him. And when he was adopted, the owners thought, gosh, we've got this really quiet, mellow, kind of easygoing dog. He was not a problem. He didn't take a lot of exercise. He was very, very comfortable member of their family. But about 2 weeks before he came in to see us, he just hadn't been quite right. And it's a really ain't doing right kind of a story. So a bit listless, a bit off. And then 10 days before he came to see us, the 2 little girls in the family had gone off to summer camp. And that seemed to really set him back. He was more depressed, more disinterested. His appetite was okay, not great. His stools were sometimes a bit squishy, not terrible. And then what actually prompted the owner to bring him in was he'd vomited a little bit of his dinner the night before. And then the morning he came in, he'd actually didn't want to eat, and he'd brought up some kind of bile fluid. And so at that point, they thought we should just go ahead and bring him in. And on physical exam, there really wasn't a lot. I mean, he was kind of quiet for a 2-year-old German Shepherd dog, but sometimes they're more mellow than others. Physical exam, pretty unremarkable. Maybe some slight abdominal discomfort. He would kind of splint when I prodded his tummy, but there was nothing really I could put my hands on at all on my physical exam.
So kind of going back to that glass slipper a little bit, I mean, that's a pretty vague history and presentation. It sounds like it could fit a whole lot of different things. So can you tell us about your diagnostic approach with Prince? Was this a case where you already suspected Addison's? Because the disease is pretty uncommon, correct? And this isn't necessarily like the breed and gender that we would expect with Addison's.
Those are 2 really good points. Yes, Addison's really isn't a very common disease. The prevalence is relatively low. And certainly when somebody says, describe the prototypical Addisonian, I would say, ooh, a 4-year-old female or female spayed, Portuguese water dog, West Highland White Terrier, Great Dane, ooh, Black Standard Poodle. Those would be the breeds that come to mind. But I would also say you're never too young, never too old, never too big, never too small to have Addison's disease. And so was it obvious that he had Addison's? No. My first thought, in all honesty, for a German Shepherd with kind of GI stuff is he's probably got an enteropathy. I do think a lot of German Shepherds are not blessed with the best of bowels. And so my first thought would be he's going to be one of those kind of inflammatory bowel disease, antibiotic responsive enteropathy. That was potentially my first general assessment of him. But whenever I see an ain't doing right, and whenever I see I think it's an enteropathy case, I pull out the glass slipper, because a lot of those patients at first glance look like a dog with some kind of chronic grumbling gastrointestinal disorder. So wasn't top of my differential list, but absolutely I would write Addison's on my possibilities for this patient. And I've kind of trained the students to always say, and it could be Addison's, because yes, it could be. So it wasn't a slam dunk by any means, but it was on my radar screen for sure.
Where did you start with your diagnostic approach? Was it kind of some basic blood work? I know you noted the abdominal splinting. Did you go to X-ray? Where did you start with this guy?
As an internist, blood work kind of sort of is my life. And so my first instinct is to always do a CBC, a chem, and then if I can get a urine, I'm going to do a UA as well. So kind of my internal medicine kind of minimum database. I don't tend to move to imaging unless I've got acute vomiting or evidence of something more significant on abdominal palpation. So my first instinct with this, I've not been right for a couple of weeks. I didn't think it was a surgical belly. I thought much more likely it's a medical condition. And so the lab work is going to be my first place to start.
Here we have a look at Prince's lab work, the way that it came back. And looking at the CBC, it looks like all of the cell lines came back within the reported, normal ranges. I have been taught to look for an eosinophilia on the CBC with Addison's disease. Is that something that you typically look for?
That's a great question, Cassie. I mean, certainly if I think about the textbook Addisonian CBC, I'm going to look for a lymphocytosis and an eosinophilia. Having said that, though, an awful lot of Addisonian patients actually fall nicely still in the reference range. And so the majority don't demonstrate a nice lymphocytosis and a nice eosinophilia. Often what we'll see is a CBC that, much like Prince's, is remarkably normal. And I have a phrase I use with the students, which is, normal's not normal when you're not normal. So if this is a patient coming in who's very healthy and I'm doing routine screening lab work before an elective surgery or annual wellness lab work, and I get a perfectly normal leukogram, neutrophils are in the reference range, lymphs in the reference range, monos and eos in the reference range, I think that's really appropriate. But when I see a patient who's coming in to see me because they're not well, I'm actually expecting to see some kind of a stress response. And there's lots of discussions about which is the hardest and fastest findings on a stress leukogram. But usually a lymphopenia is going to be the first thing we'll see in a patient who's showing us a stress leukogram. So lymphocytes go down and the EOs usually go to very, very close to 0 or 0. And so we look at Prince's and he's got plenty of lymphs in the reference range, but they're abundant. And he's also got more than 500 eosinophils. And that rolls me into my rule of 500. Which is, I think a sick animal should always have less than 500 eosinophils. So if I see a patient who is ill and they have more than 500 EOs, I always stop and think, aha, what are the differentials for an eosinophilia? Because in this set of circumstances, that is an inappropriate eosinophil count. I run those through in my mind and Addison's is going to be on that list. And so to me, the absolute normality of Prince's CBC is a red flag that he actually could be Addisonian.
I love that you're leaving us with all of these gems. We have try on the glass slipper. We have normals, not normal if you're not normal. And now we have the rule of 500. This is great. I'm taking all of these and storing them away in my brain for later use.
Wonderful.
And kind of going back to the lab work here, can you tell us about your interpretation of the chemistry?
If you look at the chemistry, it's generally okay. Most things are sitting within the reference range. The glucose is bottom end of reference range, but it's still normal. The cholesterol is low though, and cholesterol is probably one of my favorite lab work parameters because it is so closely associated with endocrine diseases, which is my passion, and GI diseases, which is my kind of secondary passion. So when I see a low cholesterol, that really catches my attention. And so my first thoughts with that are you've got an enteropathy, so you can't absorb fat properly, you can't produce enough cholesterol. I do briefly think about, gosh, could this be a hepatopathy? So you can't make any cholesterol because your liver's diseased, or is it something endocrine like Addison's? And so Addison's is the endocrine reason for a low cholesterol. So there's only really 3 reasons for that. And so again, nothing very specific on this, but the low cholesterol to me is a really, really useful clue and always catches my attention. Looking at the rest of his lab work, everything is pretty ho-hum. I do think though his electrolytes, although again, sodium and potassium are in the normal range on Prince, but the relationship between the two is slightly off. His potassium is fairly robust for a patient who's not eating well and vomiting. And so most of our patients with primary GI disease tend to walk in with a potassium that's the bottom end of the reference range or even subnormal. So robust potassium in the face of GI upset, to me, again, is a little bit of a, that's a potentially, might mean nothing, potentially a really, really useful clue that something may be impacting his electrolyte homeostasis.
So it sounds like we've gotten some clues from the blood work. I mean, Addison's is definitely on the differential list at this point, but still not really like a slam dunk, which is fairly common with Addison's. I mean, I was always taught that this disease is the great pretender, and that's why it's so often overlooked. What are some of the reasons for that?
I do think it really is the great pretender. That's a wonderful expression. I think patients in the pre-crisis stages, and I would put Prince as, he's probably maybe a week away from crisis. He's a pre-crisis patient. First glance, you tend to think it's GI disease. Sometimes you think, oh, it's liver disease, because you'll see low cholesterols, lowish albumins, kind of tummy upset. And so I think it's very easy in the pre-crisis patients or the atypical Addisonians to think this is gastrointestinal or hepatic. And so very, very easy to overlook it. And then when they do hit the crisis, we get patients who are very, very dehydrated, very, very azotemic, very compromised with a high potassium. And so at first glance, you can also think, gosh, no, this is fulminating kidney failure. And so I think it's terribly easy on Addisonian patient to do a first pass on the case and think of things that are very, very common and kind of leap right out. And Addison's is just kind of lurking discreetly in the background. And so it does tend to look like other things, which is why you've got to really kind of microanalyze the information you've got and just see, is there a smell of Addison's? Should I whisk out the glass slipper and see if I can shove it on? Have I found Cinderella? Could be an ugly sister. Could be this dog has a chronic enteropathy, which is fine. More frustrating than Addison's. Well, you'd rather have Addison's than a chronic enteropathy if you're a German Shepherd dog. But I agree, it's very, very easy to not spot Addison's. And I always tell the students that most Addisonian patients have actually seen a vet 3 times before the diagnosis is made, because that certainly has been my experience, because they're subtle and it does come in masquerading as something much more common.
Absolutely. I'm thinking of a patient of mine from several years ago who it was the low albumin on her blood work that finally gave us the clue. And I would love to say it was me that caught that and made the diagnosis, but it was Mike Scher at UF, endocrine guru, who did it. And she ended up being an atypical Addison's, but yeah, she was overall like fine. She would just kind of have these ADR episodes periodically. So learned a lot about, the great pretender and really looking for these cases from her.
I do think that's where looking at the CBC is particularly helpful, because for me, that very normal CBC with more than 500 EOs really helps me keep Addison's on the desktop of my brain when I'm looking at this patient. And it's going to be something I want to cross off really quickly, partly because I can prove it. It's a very, very provable diagnosis and I can treat it. And the outcome is awesome. And so you never want to step over a rare but phenomenally successful disease and then get lost in the weeds looking for something that's actually just a lookalike and isn't actually what's going on.
And that's the perfect segue into treatment. So let's talk about treatment. Can you review some of the most important considerations when we have a patient who presents in crisis, or maybe something like Prince, where it's a little bit more vague and mild presentation?
So those are great questions. First of all, if I've got a patient like Prince who's kind of in the stable outpatient level, then I've got plenty of time to establish a diagnosis. And so first thing I would do for Prince is I would just simply measure a baseline cortisol. And I will do an awful lot of baseline cortisols that I'm on clinics. It's kind of stuck onto my to-do list for most of my ain't doing right, unexplained weight loss, chronic enteropathy suspects, liver disease suspects, just those patients that are nebulous. I'll say, let's do a baseline cortisol. Because we do know that if your baseline cortisol is more than 2, we can abandon the idea of Addison's, presuming that no one's given you any drugs that can cross-react with the test. If that baseline cortisol is less than 2, then I have to get the patient back to do an ACTH DIM test to prove the diagnosis. If I've got a patient who comes in fulminating crisis, I'm going to go straight to that ACTH DIM test if Addison's is even faintly a possibility. So anytime I get an azotemic hyperkalemic patient, I'm going to say, this is horrible kidney disease, or fingers crossed, this is Addison's. And so I'm going to go ahead and do my STIM test in those patients just on the get-go. I must admit, I am reluctant to treat for Addison's until I've confirmed the diagnosis. The exception for that would be a patient who really is in Addisonian crisis, and I'm really sure that it's Addison's, even if I haven't proven it. That may be a patient where if they're having difficulty maintaining their blood pressure, or having difficulty maintaining their blood glucose, I'm going to go ahead and at least give them glucocorticoid support until I've managed to confirm my diagnosis. Effective fluid therapy in the crisis Addisonian will usually keep the electrolytes on track. And so it's not a huge rush to go ahead and give anything to replace the missing aldosterone. But some of those crisis patients do need dexamethasone immediately in order to become stabilized. So in a patient like Prince, he's an interesting one because right now his electrolytes are still normal, but I think they're drifting. So I think he's a patient who's going to need both glucocorticoid replacement and mineralocorticoid replacement. Some of the patients we see with Addison's, the ones we call atypical, always manage to keep their electrolytes in check, and so they can get by without needing any aldosterone replacement. Obviously, patients who are in crisis, who have hyperkalemia, hyponatremia, and are azotemic, they absolutely need to replace the missing aldosterone. And in the short term, in the clinic, in the really crisis patients, I'll sometimes do oral fludrocortisone just to kind of make a little bit of a bridge until I've confirmed the diagnosis. Once I know that they've got Addison's disease for sure, then I'm going to go ahead and reach for the Zycortal, which is a pure aldosterone replacement. And that's going to step in and do exactly what their aldosterone was supposed to do.
And Zycortal is one of the products available out there to treat Addisonian patients. Can you tell us a little bit more about that medication?
So I am old enough to have been around when the DOCP first appeared, and what a transformation it was, because way back in the early 90s, the only way that we could manage these patients was to use the fludrocortisone, and it was very, very unsuccessful. If you could get enough fludrocortisone on board to make them keep their electrolytes in track, the dogs were overtly Cushingoid because that drug cross-reacts with the glucocorticoid receptor, and so you had these kind of Cushingoid dogs, which was very disappointing. So when DOCP came along, it was miraculous because it is a pure aldosterone receptor agonist, and so it does exactly what aldosterone is supposed to do. It's also great because it's given by injection. And the Zycortal has the advantage of being licensed specifically for subcutaneous use, which makes it very, very easy for owners to do. And so some people will still bring their patients in to see us for their Zycortal injection in my practice, but usually I'll teach the client to do it at home, and that reduces the expense from the owner's perspective and improves compliance because they're not forgetting to come in or trying to stretch out the appointment. They've got the drug to hand and it's very, very easy to administer. So we do need to make sure that the Zycortal is doing what we need it to do. So there are some very clear guidelines in the package insert about bringing the patients back in for a check on their electrolytes about day 12 to 15, and then at the end of the Zycortal injection, which is about day 25. I must admit that I do sometimes stretch out the frequency of administration to make it once a month because I think it's much easier for owners to remember to do that. And most patients actually can stretch it out, so it's just a once a month injection.
Wonderful. I mean, easy peasy as far as the treatment goes. And, kind of to wrap up here, let's talk about Prognosis, which is one of the best parts of Addison's disease. I mean, these guys have a great prognosis. Is that correct?
That is correct. It is one of the best reasons to be coming to the doctor's office because we can diagnose it definitively and then we have highly effective treatments. And so from my perspective, a diagnosis of Addison's is a yay moment. I mean, I just do the happy dance when I get that answer back because I know exactly what I'm dealing with and it is so incredibly treatable. So long-term prognosis for a dog like Prince is excellent, absolutely excellent. He's going to be maintained on his Zycortal injections. He's going to take prednisone every day for the rest of his life. If he's facing a stressful event, if the kids go away to summer camp again and he gets sad, or if he's having a procedure, he's going to be boarded, he's having a day at the groomer, anything that might be stressful, then we give his owners instructions about increasing that daily prednisone dose just to give him a bit of a stress buffer, basically, so he can go through those more difficult times. And then usually I'll see these dogs back a couple of times a year to make sure that everything is on track and kind of tweak my dose on the prednisone if they seem at all overdosed on that, and make sure that my Zycortal dose is also on track. And that reminds me, I must admit, I do tend to drift down from the package insert dose on bigger dogs when I'm using the Zycortal. And often I'll get away with a dose that's about 2/3 of the package insert dose in the bigger dogs. And that can be a significant cost saving for the owner. So I think it's worthwhile playing with that just a little bit.
And did this prognosis expectation apply to Prince as well? How did he do once he was treated?
Oh, absolutely. He did great. What was amazing, though, is the owners came to pick him up and basically couldn't recognize the dog in the sense that we sent home this bouncy, rambunctious, trying to jump up on people, wagging his tail, meeting strangers dog that they had actually never known. And so I do think with hindsight, he'd been slipping into an Addisonian state probably before they adopted him. And so hence their quiet, mellow, easygoing, low stress 2-year-old German Shepherd. They took home your kind of standard, bouncy, crazy, licking everybody, just crazy. It was hilarious to see the change. And I think the little girls were delighted that their dog was so much bouncier. I'm not sure mom was so pleased to get home a busier, bouncier dog, but he looked fantastic.
Try on that glass slipper and it fits and everybody lives happily ever after.
Absolutely, absolutely. So it is a wonderful disease to diagnose. It really is it's just cheers all around at work when we get an Addisonian, because it is such an awesome disease.
Absolutely. Absolutely. Well, Dr. Cook, thank you so much for being here with us today. I mean, I learned a ton just from this brief conversation, and really appreciate you going through this case study with us.
Oh, I'm happy to do it. It's a great disease to diagnose, and I'm happy to talk about Addison's for an hour.
I know we could go on and on and on.
Thank you so much, Cassie.
Absolutely. It was wonderful to have you. Thank you again. And thank you to DECRA for sponsoring this edition of Vet2Vet. We hope to see you back for our next in-depth discussion. And remember, if one animal is better off because of you today, it's a great day.